Mr. Scott.
Good morning, my lady. Please may we call Professor Sir Michael McBride, who can be sworn.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
nothing but the truth.
Welcome back, Sir Michael.
My lady.
Good morning, Professor McBride.
Good morning.
You have been Northern Ireland's Chief Medical Officer since September 2006.
That's correct.
I'm just going to set out a little bit of your professional background. So, from 1994 to 2006, you worked as an HIV consultant at the Royal Group Hospitals Trust in Belfast.
That's correct. Yes.
You were appointed Medical Director of the Royal Group of Hospitals in August 2002. In September 2006, you were appointed as Northern Ireland's Chief Medical Officer. Between March and August 2009, you were appointed Acting Permanent Secretary at the Department of Health and Chief Executive of the Northern Ireland Health and Social Care at the request of the then Minister.
That's correct.
From November 2014 to February 2017, at the request of the then Health Minister, you were appointed as Chief Executive of Belfast Health and Social Care Trust, and you served until February 2017, and that was in parallel to your role as CMO.
That's also correct, yes.
You're a Fellow of the Royal College of Physicians in London and of Ireland. You've been awarded an honorary professorship and doctorate by Queen's University Medical Science for Distinction in Medicine, and in March 2022 you were elected to honorary fellowship of the Faculty of Public Health.
That's correct.
And then you were knighted in 2021 for services to public health in Northern Ireland.
Yes.
Professor McBride, I just want to provide a brief overview of the structure of the healthcare systems in Northern Ireland. I'm very conscious that my lady's heard this in both Module 1, also has an understanding from Module 2C. So we're not going to go into this in great detail, but just to help identify matters. Starting with the name, it's not called the NHS in Northern Ireland, is it? It's Health and Social Care.
That's correct. I mean, the NHS refers predominantly to England, but certainly in Northern Ireland it's referred to health and social care. It's really an umbrella term which we use, which refers collectively to the roles and responsibilities of the department, the Health and Social Care Board, Public Health Agency, and the 5 trusts.
I just wonder if you could keep your voice up a little bit. I'm having a little bit of difficulty hearing you, sorry. And it's often said that Northern Ireland's health and social care system is unique because trusts provide social services rather than local authorities.
That's correct. Northern Ireland's had an integrated health and social care system since 1973.
And the Department of Health lies at the top of health and social care as responsible for healthcare policy. That's correct?
Correct. Policy, legislation, setting priorities, allocating funding to the rest of the system.
And then I'm just going to skip over HSCB for a minute. There are 6 Northern Ireland health and social care trusts, 5 geographical and 1 ambulance service. That's correct?
That's correct.
And the trusts are responsible for effectively implementing departmental policy. Is that right?
They are, effectively delivering services according to standards which are set by the department.
And just to have a flavour of effectively what's on the ground for patients in Northern Ireland, how many hospitals are there in Northern Ireland? About 19?
About that, yes. I mean, obviously it's a changing landscape because there is ongoing structural reform, and the range of services provided in each of those is currently being looked at and being reviewed.
And in terms of the regional distribution of hospitals, there are a couple of hospitals in Belfast, but would you say that they're fairly well distributed across Northern Ireland?
They are. I mean, the vast majority of the regional services, so for instance, neurosurgery, regional vascular surgery, the very specialist services would be provided within the Belfast Trust, although there are some elements of those services also provided elsewhere. So there's a concentration of regional services in larger geographical conurbations, so in Belfast, Derry, Londonderry, and also then there are a range of more general hospital services and local hospital services to meet the needs of local populations.
So if you're living in Northern Ireland, what's the kind of furthest in terms of driving distance you'd ever really be from a hospital?
I mean, certainly in some rural parts of the west of the province, probably within 60 to 90 minutes would be about the longest time journey to a specialist centre.
And as you say, if most of the very specialist services are focused in Belfast, it would take 2 to 3 hours at most for anybody in Northern Ireland to get to those centres. Is that right?
Probably considerably less than that. I mean, obviously we do have specialist transport services in relation to road transport through Northern Ireland Ambulance Service, but we also have the Northern Ireland Air Ambulance, which, in very, very time critical incidents. So, for instance, if there's a significant trauma, or indeed if there's a significant medical or surgical issue which requires rapid transfer, then we would use the Northern Ireland Ambulance Service. We also have, again, a very specialist, Northern Ireland specialist retrieval and transfer service, NISTAR, which is responsible for the rapid transport of patients to specialist centres should they require care there.
And in terms of the intensive care units in Northern Ireland, about 10 of them?
Yes, some are in that region.
And roughly, how many GP surgeries were there in, or maybe it's easier to say GP's practices, in around March 2020?
At around that time, and there were somewhere in the region of 320 general practice services. That number has decreased more recently, and I think currently there are around 312.
I said I was skipping over HSCB. So in terms of the relationship, you have department at the top, and is it right that the department issues an annual commissioning plan direction?
That was the case prior to the pandemic and prior to the board, the closure of the Health and Social Care Board, and then it being amalgamated into the department. But that was historically the approach that was taken.
Yes, sorry, I should have clarified. So in, let's call it January 2020, that was the position. The department issued a commissioning.
That's correct.
And then you had the Health and Social Care Board, and that was responsible for governance of commissioning.
Yes, the commissioning plan direction was issued by the department. It was then considered by the Health and Social Care Board with the support of the Public Health Agency. As the joint commissioners of services, a bit like the commissioning model that still exists in England, the board and the PHA then would have engaged directly with the trusts, and each trust would have developed what was called a service and budgetary agreement. So basically, here are the priorities the department has set. This is how we will meet those priorities within the resource that we are allocated. So it was a very, I suppose, a very well-defined transactional process. And then the board, Health and Social Care Board, would have performance managed the trust to ensure that the trust delivered on their commitments within the agreement.
And then just to get a flavour of what that would have looked like, I say the plan that was in place at January 2020, what would those priorities have looked like in terms of the headline priorities?
Well, those priorities would have covered a wide range of issues. So, for instance, it would have covered issues around waiting times for outpatient appointment, waiting times for inpatient treatment, specific targets and around cancer waiting times. So a range of service-specific targets, but it would also have included quality indicators. So it would have contained targets about reductions in healthcare-associated infections. For example, it would contain targets about reducing the prescribing of inappropriate prescribing of antibiotics. So a range of both service metrics, but also quality improvement metrics. Now, that's only a small example. These were extremely comprehensive documents with a significant number of targets within them.
And it had been the intention from 2015 that the Health and Social Care Board, HSCB, would be closed, and the intention of that was to enhance the department's strategic leadership and control of the system. Is that correct?
Yes, that was the decision made by the then Minister back in November 2015.
And why was that considered necessary to enhance the department's strategic leadership and control of the system?
I think the general view was that Northern Ireland perhaps was too small a health economy to have a separation or a very distinct separation between department, the commissioning of services, and then the provision of services. And there was a move then to ensure that, and which that journey has continued, that we move to a much more integrated care system, which actually puts at the heart of it local communities, puts at the heart of it not just delivering services, but improving the health and well-being of the population, which was a core priority of the reforms to health and social care that happened in 2009. We do benefit in Northern Ireland from having an integrated health and social care system, as you say, and this was seen as an opportunity to make sure that we derived the full benefits of that integration. And I think it's probably important to make this point because it was a real strength during the pandemic. There is the interconnectedness of the various elements within Northern Ireland is more straightforward, given the fact that we are a relatively small geographical area, and that was a significant strength during the response to the pandemic, where we responded effectively as a single entity. But I think the overall impression, to answer your question, was that we had too many layers, perhaps, and that there was greater efficiency to be gained by collapsing some of those layers.
Well, that was where the question was going. So HSCB hadn't been closed prior to April 2022.
That's correct.
That's correct. So did Northern Ireland miss out in the benefit of having that collapsing of those layers during the course of the pandemic?
I think if indeed the intent achieved the outcome that was the purpose of those changes, I think the answer to that is yes. I think we're still working through that transition period because the Health and Social Care Board then became part of the department in April 2022 and is now the Strategic Performance and Planning Group within the department. And we are now advancing the new model for the integrated care system, which I alluded to earlier. I think that there was undoubtedly a period, and I've alluded to this in my statement, of uncertainty between that announcement being made in 2015 and then that being realised in 2022. But of course, we didn't have the wherewithal to give effect to that because we had no ministers for 3 years during that period.
Did it feel like during the pandemic there was too much distance between the department and the trusts?
No, absolutely not. I mean, as I say, and I've tried to articulate this in my statement, there was a very close working relationship between the trusts, the Health and Social Care Board, the PHA, and indeed the department across a whole range of areas. I mean, that was both by necessity and by design. The demands on the entire health and social care system in Northern Ireland were immense during the pandemic. It was only by working collectively and effectively as a single entity that we were able to respond efficiently and effectively to those demands. And I think that interconnectedness, that ability to get people into a room, although of course during the pandemic we couldn't get people into a room, but virtually have discussions with people who we all had good working relationships with, served us very, very well and hopefully served the population of Northern Ireland well.
Just want to move now, looking at your roles and responsibilities and then structures during the middle of the pandemic. I'm going to deal with these relatively briefly. So your role is to provide independent professional advice to the Health Minister. You're accountable to the Health Minister and you are also accountable to the Permanent Secretary in his role as the Department's Accounting Officer. Is that correct?
That's correct, yes.
You say that your role is to provide independent professional advice. Independent of what? Independent of political influence or other considerations of that nature. If I'm asked for my professional opinion, I base it on evidence,
That evidence could come from research. That evidence could come from expert clinical opinion, which I rely on as well, and knowing the limitations of my own knowledge, and also relying on expert clinical opinion. So the amalgamation of and triangulation of all of that would inform my professional advice. So I don't take any other considerations on board. My advice is my advice, and I provide that independently of any other considerations.
Because you're in a slightly different position, for example, to Professor Sir Chris Whitty, where OCMO is a different, effectively, structure. You are very much within the Department of Health.
Yes, I mean, it's a different role with different responsibilities, and it's a different system. But it is the system that, as was designed in Northern Ireland, it was the job to which I applied and the job to which I was and the role that I was appointed to.
Because as CMO, you are also a member of the department's top management group, which is the main vehicle for managing the department on a day-to-day basis. That's
Yes, correct.
And what was your working relationship like with senior figures at the start of the pandemic? Because, for example, the Health Minister, Robin Swan, started in his role on the 11th of January 2020. So how easy was it to build a working relationship with him?
I mean, the success or otherwise of any chief medical officer is to build effective working relationships with senior colleagues within the department, and certainly with ministers, and to ensure that at all times through the advice that we provide that advice, as we've discussed, professional advice in an impartial way to the best of our ability. So the fact that the pandemic hit some 3 weeks after the executive had reformed, there were new ministers in post who were really just getting into their brief. It did present some challenges. However, I have to say that, as with all previous ministers, I rapidly developed an effective working relationship with the then newly appointed Health Minister, Minister Swan.
And in terms of the Chief Scientific Advisor for the Department of Health, and also the Chief Nursing Officer at the time, both of them had come from the Belfast Trust before they were appointed CSA and CNO, is that correct?
The Chief Nursing Officer, former Chief Nursing Officer, had also worked in a number of other organisations in Northern Ireland. She'd served in the South Eastern Trust previous to working in the Belfast Trust. I had known her in both of those roles. And it's correct, yes, the Chief Scientific Advisor had previously worked as a joint appointment, an academic appointment between Queen's University Belfast and the Belfast Trust.
But both of them had been subordinates to you within the Belfast Trust, is that correct?
I wouldn't describe the then former Chief Nursing Officer who gave evidence earlier or last week was Deputy Director of Nursing in the Belfast Trust at the time, and she was accountable to the Director of Nursing in the Belfast Trust. So there was no reporting line to me. So she was not, and I would not regard Charlotte as subordinate to me. I mean, she had a range of expertise and competence and experience in areas that I wouldn't have had.
But when a group of people travel effectively up through the ranks together, that working relationships can form, was there a culture of challenging and testing your views and your advice that you're providing as CMO?
Yes. I mean, I think that I think my approach to these things is to surround yourself with very able people, many people often who are more able and knowledgeable about a particular subject than you are, and to ensure that they are empowered to challenge and to question, and it's my responsibility to listen, to hear, and to act on that accordingly. And there were many examples where the Chief Scientific Advisor would have had perhaps not a different view, but a nuanced view or interpretation of the science, for instance, during the pandemic, and I would very much have taken on board and in many instances been guided by his advice. Similarly, with the Chief Nursing Officer, who, by nature of the demands at that time, there was a division of responsibility. There had to be a division of responsibility because, it was not possible for me to be involved, or nor would it be appropriate. So again, the then Chief Nursing Officer would have led on material issues. I would have provided advice and support to her.
Forgive me, Professor McBride, can I just cut through this? We will look at specific examples and about the interactions, but you're satisfied that you were having your views and your advice challenged by those people that you were working with. When I say challenged, I don't necessarily mean in a detrimental way, just it was being tested and it was being effectively made sure it's as good and as strong as it possibly could be.
Yes, we were dealing with such uncertainty at that time that we relied on each other to challenge these fine, at times very finely balanced judgment calls that we were making. So that challenge was absolutely vital and essential.
Because I think you mentioned earlier on about the size of Northern Ireland and therefore the size of the size of teams of those who can be within the health service. So as CMO, you're head of the Chief Medical Officers Group, and that's comprised of yourself, 2 deputy CMOs and several medical advisors. How many advisors were in the team?
The senior medical advisors, there were 4 in total, two of whom were part-time.
So it's a team of 7 within your group. So yourself, the 2 DCMOs, and then the medical advisors.
Not 7 full-time equivalents. As I say, there were 2 full-time DCMOs, myself, and 2 full-time senior medical officers and 2 part-time.
And so just to have a look at some of the aspects that your role covered. So CMOG acts as a sponsor for the Public Health Agency and the Regulation and Quality Improvement Authority. For those people who aren't necessarily familiar with all the bodies, that's broadly equivalent to the CQC.
That's correct, yes.
And how much time did that take up in your role as a sponsor of those 2 bodies?
The sponsorship would have largely been managed by policy officials within CMO Group, so they would have dealt with the day-to-day issues. I would have attended and sponsorship review meetings and accountability review meetings with the permanent secretary, and if there were issues that arose, then those would have been brought to my attention, but I wouldn't have been involved in the day-to-day sponsorship arrangements.
Okay. So role also included Population Health Directorate, which at that time included responsibilities for health improvement, health protection and emergency planning. I think, as was noted in the Module 1 report, my lady, paragraph 2.78 for those who wish to review it. Since that time, Chief Medical Officers Group has been restructured with the establishment of a Health Protection Directorate and an Emergency Planning, Resilience and Response Directorate following an internal review. But I think it's actually right, Professor McBride, that even since then, Chief Medical Officers Group has been further restructured in November 2023. So the Population Health Directorate, Health Protection Directorate, Emergency Planning, Resilience and Response Directorate, and the Quality and Safety and Improvement Directorate are no longer part of your group.
That's correct.
That takes me to the question. Why have they been removed from within the responsibility of CMOG?
I think this was a decision made by the new permanent secretary, one that I supported in relation to some internal restructuring within the department. I think it was in part an acknowledgement that the responsibilities and the remit that I was carrying were very broad, and the demands of that were very significant. And it was an opportunity to provide some, it built on the work that I had already done in terms, which you alluded to, in terms of separating out the Health Protection Directorate and the Emergency Planning and Response Directorate. So I think it also had the advantage of freeing up more of my time professionally to provide advice and support across more areas of the department. because as well as my policy responsibility at that time, I also had professional responsibility to provide advice and support to other policy areas, such, for instance, primary care, mental health, etc. And having the policy responsibilities, the budgetary responsibilities, the HR issues responsibilities was not seen, and I would agree, as necessarily the most effective use of my time.
Professor McBride, I'm afraid sometimes your voice goes down,
Okay.
it becomes very soft at the end of a sentence, and you speak quite quickly, and both the stenographer and I are struggling a little, so if I'd encourage you to speak slowly and to speak up, I'd be really grateful. Thank you.
Yes, my lady.
Just moving now to the HSC structural response to the pandemic. So we've heard that the tiers of the emergency response within the health system generally are referred to as Health Gold, Health Silver, Health Bronze, and those are the strategic, tactical and operational response. Let's kind of move past the names and actually look at what they're doing. So effectively, it works from the bottom up, doesn't it? That you don't have to have gold, you can have silver without gold. And
That's correct, yes.
so Health Bronze is effectively the operational, the trust level response, is that right?
Yes.
And Health Silver, that's not actually a departmental body, is it?
No, it isn't.
So that's made up of the Public Health Agency, what was HSCB at the time, and then also the Business Services Organisation. So did the department have no role in Health Silver?
No, it's not to say that we had no role. In any emergency situation, the principle of subsidiarity applies, so that all issues are managed at the lowest possible level and escalated to the next level as required for decision. So the department, when the full bronze, silver and gold arrangements were activated, as we would do in a significant or catastrophic incident
Such as the pandemic.
such as the pandemic, then the department would activate Health Gold, the various...
I'm going to come on to Health Gold. It's just at the moment in terms of whether the department had any involvement in Health Silver or whether the department rested effectively within Health Gold.
Within Health Gold, yes.
And why is it the department had no role within Health Silver? Is it effectively you would have been duplicating your roles?
Yes, I mean the role of the department in a serious or a catastrophic emergency is to provide strategic direction and coordination. I mean our role, and again I think Chair, my lady, we covered this within the with Module 1, is clearly set out within the emergency response plan.
Yes.
And Silver is responsible for the coordination at a system level across the various provider organisations, and when activated and Health Gold is activated, we'll be providing situation reports to the department and would be escalating issues that required decision because of their significance or policy implications.
And we'll look at some of those in due course. And just for completeness, so those bodies within Health Silver decide when Health Silver should be activated?
Yes.
And that was activated on the 22nd of January 2020. And then in terms of Health Gold, I think you've been describing what Health Gold does. You, as CMO, are chair of Health Gold, that's right?
Correct.
And that's set out under, say, the Department's Emergency Response Plan. And effectively, your role is to oversee the departmental response. That's the title at Action Card 1 of the Emergency Response Plan. It's not my words.
Yes, it is. I'm happy to elaborate on that, but yes, it is in the action card, yes.
And yes, you have the minister above you who's effectively fundamentally responsible for the health response. Is that correct?
Yes.
And your responsibility, you're making informed decisions in relation to how the sector should respond, providing health advice, professional dental and pharmaceutical advice. Presumably that's through your chief pharmaceutical officers and others supporting you. Public health policy and safety and quality policy, including standards, guidelines, and professional regulation. That seems a very broad role. Would you be able to describe, in the middle of the pandemic, what was your typical day like? And none of us have been CMOs, Professor McBride. It'd be helpful to have an understanding of what your day was like.
There was no typical day during the pandemic because every day presented very unique challenges. I think that, I think as I've said previously in previous witness statements, I think it's now, looking back, very hard to convey both the complexity and the pace of events and the challenging and difficult issues that we were facing. And I think that was compounded by the very significant degree of uncertainty that we faced. So we were relying on what we had already, for instance, if we look at the virus, what we already knew about coronaviruses. We were relying on first principles, what we knew already about good public health practice, good infection prevention control, and we were actively seeking to generate more knowledge, more information, more evidence, reaching out to other countries who were slightly ahead of us in the pandemic, China, other European countries, Italy, France, to ascertain the impact that the virus was having, how the disease was manifesting, those that were most at risk. Actively at that time, even then, thinking about research for novel treatments, looking at previous treatments for other viruses, again thinking through vaccines and starting up vaccine research trials. Also thinking through and planning the measures that we would have to put in place at a population to contain the virus. It was clear very early on that this was a highly contagious virus. It was an extremely infectious virus. Our knowledge of how it was spreading, where it was spreading, was significantly constrained by the level of testing that was available to us at that time.
Professor McBride, I don't want you to jump too far ahead of me. We will be going through this in terms of the time. It's just a matter of, just to give a flavour of the issues that you were facing. Can I just ask a very simple, hopefully fundamental question? Do you think you did your best for the population of Northern Ireland in response to the pandemic?
I think each and every one of us, from those in the front line to those of us in government, to ministers, to every minister sitting around the executive table, at all times try to do our very best. I don't think that that there's any doubt about that. I think that, and we did that, based on the knowledge and information that we had at that time, and ministers made some very difficult decisions, weighing up some very difficult issues in terms of the health consequences, the social consequences, the economic consequences. All of us were very mindful of the impact that it was also having on the health service, on routine services that people would normally expect, the care they would normally expect, and the fact that we were having to ramp up services to deal with the anticipated surge in people requiring respiratory support and intensive care, and that was constraining our ability to deliver care as we would do. So we're all very mindful of those challenges. And as I said at the time, there were no easy solutions. There were no simple answers. There were just a series of very difficult challenges. And we made at all times decisions which we believed were in the best interests of the public that we serve.
So, on the basis that all decisions were in the best interest of the public that you serve. With the benefit of hindsight, do you believe you got all those decisions right? Or were there any that you wish that you had taken a different position on, even if that knowledge wasn't available to you at the time?
Well, I suppose ultimately, my lady, it'll be for the inquiry to determine in terms of the answers to that question. As I've said in my statement, I think there were some issues because of the pace of events. I think there were certainly some issues in terms of, and I'm sure we'll probably come on to this later in relation to communication. So, for instance, to those shielding, in terms of how we conveyed information, in a balanced way, which allowed people to make choices about what was important to them.
Is that within the shielding context?
Yes. And empowered them and give them a self of agency, because it became very difficult later on when actually the harm and benefit analysis changed then to provide assurance to the population of people who had been shielding, who were clinically extremely vulnerable. And looking back, I think some of the initial messaging around that could have been more nuanced. I think certainly that was something which, as I'm sure we'll come on to, I was concerned about and was concerned really from May 2020, when I'd commissioned some research to seek the views of people who had been shielding in terms of the impact it was having on them.
We will come back to that. Beyond the shielding points, as I say, are there any lessons that you personally have learned from your experience as a Northern Ireland CMO?
They're probably at several levels. I think if we take it at the personal level and the very human impacts of the pandemic, undoubtedly a piece of work that I commissioned earlier in the pandemic was around the psychological aftermath of the pandemic, when I'd commissioned that work back in March. And a consequence of that...
So just March 2020?
Yes. So very, very early on, and I had envisaged that this was going to have some fairly profound impacts. I think it's referenced in my statement. That identified that there would be impacts in those who were bereaved during the pandemic, either as a consequence of losing someone to COVID, or indeed death of someone not from COVID, because of the changes that we had to put in place around the normal grieving and cultural and ritual traditions around death. So I commenced a programme of work around bereavement support.
But in terms of how the outcome of that review report process, doesn't really matter what we call it, how did that impact upon your decision making in the pandemic? Was that something that was always at the forefront of your mind?
No, I think it was something that certainly I think that we must do better in health and social care around bereavement care and bereavement support. It was something, yes, I was mindful throughout my career. It was quite clear this was going to be a particular issue.
Clear from when?
Well, from pretty early on, I would say that whenever we introduced the restrictions in and around funerals and people paying respects.
So that late March, around the time of the
Yes. I then, I know you don't want to go through all the details at this stage, but I established a bereavement network at that stage. We developed a range of guidance and supports for people, for children who were bereaved, individuals who were had died in nursing homes, for both their carers and for staff. And ultimately, that resulted in a report which saw the establishment of the Northern Ireland Bereavement Network. And we now have, as a result of that, a Bereavement NI website, which is a source of support available to individuals who have suffered a bereavement. Now, I think that was a direct consequence of some of the experiences in the pandemic, and the fact that I think that we need to enhance arrangements in that area. Another particular area under that sort of the people bit of the learning was the work that we did around the ethics guidance and support framework for clinicians.
I will be coming to some of the details.
And another element which I think is crucially important in that same context was work that we started during the pandemic, and a policy document that we published in October 2022 around advanced care planning. And that is a systematic and structured way about people identifying when they are well, about things that matter to them, and having structured conversations with individuals that matter to them about things that they wish in terms of their personal wishes, their financial wishes, medical wishes in terms of treatment and care at the end of life, etc. And that work is being rolled out at present. So I do think that the pandemic has shone a light on that. For me personally, a very important light on the fact that there was much more that we need to do, not just as a health service, but as professionals and as a society, about encouraging those conversations and putting in place the mechanisms to support individuals.
Thank you. I want to move now to one specific area that Chair's heard a lot about over the past 2 weeks. It's infection prevention and control. What was your role in terms of the infection prevention control measures that should apply in Northern Ireland during the pandemic?
I think I did not have a direct role in the infection prevention control measures that were to apply in Northern at the time. We had an infection prevention control cell, which was headed up by the Public Health Agency, who have expertise in infection prevention and control. There is already a considerable amount of expertise in infection prevention control within the health service. So that infection prevention control cell led on the advice and guidance around those measures during the pandemic.
And I think that's set out in your statement. And I think you also say that there was, to my knowledge, no IPC guidance developed solely in Northern Ireland, and the IPC cell within the PHA in Northern Ireland did not diverge from the UK-wide IPC guidance. Is that your understanding?
Well, there was guidance developed, but it didn't differ. There was guidance provided in Northern Ireland, but it was aligned and fully aligned with the IPC guidance in the rest of the UK.
So even if you had no direct role in the creation of it, you must have been aware of the guidance.
Yeah, yes, but as I say, the nature of my other responsibilities were such, I wasn't directly overseeing that guidance or its developments, but we did, certainly the UK CMOs at our senior clinicians call, which were happening regularly, would have got updates of any developments or changes recommended in the IPC guidance. So it was a high-level involvement, but not in the detail.
You say the senior clinicians group, and you said it met regularly. Roughly how regularly?
It met weekly, and that happened really throughout the pandemic.
And those senior clinicians group, did that have any, as far as you were concerned, any oversight of the IPC cell?
No, it didn't have oversight, but certainly we would have had updates from the UK HSA representative who was sitting on, a member of the UK Senior Clinicians Group, about plans of for engagement or discussions which were to be had at the UK Four Nations UK IPC cell, of which the PHA represented Northern Ireland.
So as far as you were concerned, would you have seen it as your role to scrutinise the guidance that was coming out and apply your own personal knowledge to it?
No, I think part of my role as Chief Medical Officer is to recognise the limitations of of my expertise. I'm not an expert in infection prevention control, and there are others that are expert. I think had I been aware of something within that guidance which I felt was of concern within the limits of my professional knowledge, I would have certainly challenged that. But very much I was reliant on those who were expert in the area.
So in terms of issues such as routes of transmission, where was your advice coming from?
My advice would have been coming from colleagues within the UK HSA, and I understand you had evidence from UK HSA Health Security Agency last week. So again, that would be the source of expert advice.
So there was nothing local in Northern Ireland that was providing any separate advice about routes of transmission, for example?
No, there wasn't. And as I've made clear in Module 1, in Northern Ireland we do not have, given our scale and size, the technical ability to replicate that expertise in Northern Ireland, and that's why we benefit so much from the links and effective established links that we have with the UK Health Security Agency.
So in terms of the droplet or airborne/aerosol routes of transmission, did you have any view of that, or were you just accepting the advice that you've been provided?
I accepted the advice that I was provided.
And do you have any views on another topic we've heard about the different benefits offered by FRSMs compared to FFP3 masks?
It is clearly a complex area. I did listen to the evidence from Susan Hopkins last week. She's clearly much more knowledgeable about these matters than I am, and I would defer to her interpretation of that. We did cover this and address this within the CMO technical report, but as I say, I'm not an expert in infection prevention control, nor would I say that I'm an expert in the differentiation between aerosol and droplet. What I would say is that I think that it's probably unhelpful to have a dichotomous view between transmission, because it obviously, as was indicated, it really depends on the circumstances, very much in the environment, on ventilation, how infectious the individual is, and obviously our knowledge on the routes of transmission of SARS-CoV-2 changed incrementally throughout the pandemic. So what we understood...
This is, sorry, just to be clear, this is understanding that you've gathered from the advice that you were providing. It's not your own understanding that's grown during the course of the pandemic.
That's correct, yes. I mean...
and just in terms of the droplet aerosol dispute in terms of the route of transmission, were you aware of those two differing views during the course of the pandemic?
I would have been aware of those views. I don't recall all of the detail, but I do recall it being raised at the UK senior clinicians. There was, and I think I've also addressed this in my statement, there was a subgroup set up to establish to look at aerosol generating procedures, and there was a Northern Ireland representative on that group.
Slightly different topic though, because I think what was on the list of AGPs is a slightly different issue as opposed to whether AGP should have existed in the first place. But just one point I just want to ask you about. You say, I did listen to the evidence from Susan Hopkins last week. She was clearly much more knowledgeable of these matters than I am, and I would defer to her interpretation of that. Why would you defer to her interpretation as opposed to any of the other evidence that we've heard about the aerosol droplet?
I haven't listened to any of the other evidence. I haven't had a chance to read the other evidence. I know you have had other evidence from Professor Beggs and others, but that is not something I've had time to consider.
Okay. I want to move now then to the capacity of HSC at the start of the pandemic. Did the population of Northern Ireland have the healthcare service that they needed at the start of the pandemic?
No.
Why not?
The health service in Northern Ireland was a health service that was well overdue for structural reform. That hadn't happened for a variety of reasons. There had been a number of reviews. The more recent...
Can I just very briefly just encapsulate 2 paragraphs from the Module 1 report, just to see if you agree with them and maybe encapsulate those. So paragraph 5.83 it's reported that Professor Sir Michael McBride, Chief Medical Officer for Northern Ireland from September 2006, told the inquiry that the health service in 2020 was not even as resilient as it had been in 2009. That's correct?
Yeah, I agree with that, yes.
And paragraph 5.84, issues of funding are political decisions that properly fall to elected politicians. However, it remains the case that the surge capacity of the 4 nations' public health and healthcare systems to respond to a pandemic was constrained by their funding. Again, you agree with that?
Yep.
So I don't want to go too far behind funding issues. But, for example, was health and safety, was HSE actually equipped to meet the needs of the Northern Ireland population at the start of 2020?
No, I don't believe it was, and I think that that's demonstrated by the problems that the population was experiencing with access to care and the frustrations that those providing that care had been experienced for many, many years. And as I've said in my statement, I think that many health professionals, those working in the service, the leadership in the service were increasingly becoming demoralised at the gap between the need and our capacity to deliver that.
Can I please show you, it's INQ 000374049. This is the elective care framework report from June 2021. I presume a document you're very familiar with.
I am familiar with it, yes.
And it was one that's produced by the department, so these are the department's words.
That's correct.
And then it's that section under waiting times pre-pandemic. So waiting times in Northern Ireland were at an unacceptable level before the pandemic and have been worsening steadily since 2014. In March, so prior to the pandemic, waiting times for elective care were the worst in the UK and among the worst in Europe. And in terms, if we can just go down 3 paragraphs, waiting times are currently so long in Northern Ireland that emergency departments and other urgent pathways have increasingly become the default entry point for patients requiring treatment, either due to patients waiting so long that their condition becomes urgent or because EDs are seen as a faster way of accessing diagnosis and treatment. Fixing waiting times will therefore also help take some of the pressure away from EDs. Did that reliance upon emergency departments have an impact upon the way that the population or the healthcare system responded in the early stages of the pandemic?
I think it affected our capacity to respond. It reflected on our capacity to surge, to respond to the demands of individuals presenting with COVID that needed care. And I think as a consequence of this, elective services in Northern Ireland were downturned earlier and for longer than in other jurisdictions. And I think that is something which is also covered within that report.
Yes, I think that's a line from the report itself. But does that also end up in a cultural situation where the population are likely, even in the early stages of a pandemic, to go to an emergency department rather than seeking help initially from any other source?
Potentially, but that's not what happened. And I can elaborate on that if you wish.
And if we can just go, please, just in terms of waiting times and comparisons across the United Kingdom, if we can go to page 27, which is internal page 26 of this document. Thank you very much. And it's that middle paragraph. I think the opening line of the paragraph above, we don't need to highlight it, does say direct comparison is not readily available because of the rest of the UK. Waiting time data is no longer collected, as is the case in Northern Ireland. But this is the comparison that's been drawn by the department. So pre-COVID figures, in England at the end of November 2019, 1,398 people waiting more than 52 weeks on the pathway to start treatment, whereas in Northern Ireland, population of 1.9 million, there are over 100,000 people waiting for more than 52 weeks for their first outpatient appointment. So effectively, comparatively, about 2,000 times worse? Is that?
Yes, roughly, yes.
Thank you, that can come down now. Are the reasons why those waiting lists in Northern Ireland were so long compared to the rest of the United Kingdom, are those reasons relevant to HSE's ability to respond to the pandemic, particularly in those early stages?
I think in relation to the negative impact that there was on people waiting for planned care, treatment and care, absolutely yes. In relation to the ability to respond to people requiring acute care for a range of medical and surgical conditions, no. And and if we look at its ability to respond to people needing acute care from COVID, no. But there's absolutely no doubt that there was an extremely negative consequence for people waiting for planned care that was delayed during the pandemic, that was delayed further than elsewhere and delayed for longer than elsewhere as a consequence of the situation that the health service in Northern Ireland was at the start of the pandemic.
Want to move now and look at initial planning and the response. In your statement, you refer to your role leading and coordinating policy and operational oversight of the public health and health service response to the 2009 H1N1 pandemic. So you'd had some experience of how to respond in the initial stages of a pandemic prior to the COVID pandemic arriving. In terms of the planning plans experience that have been available to you in January 2020, what did you have at your disposal? What tools were there for you to be able to respond?
Well, in terms of tools, we had the Northern Ireland's crisis management arrangements in terms of at the highest level of government for activation of those arrangements. We had within the department's emergency response plan, which I alluded to earlier, which basically laid out a very systematic way of responding to such situations with a modular approach with the various levels, bronze, silver and gold.
Both of those are structural responses?
Yes.
In terms of, and I probably should ask the question more specifically, in terms of the healthcare response, what was available to the healthcare system in Northern Ireland about how it should respond to a pandemic?
Well, within Health Silver, they have a joint response emergency protocol which has been in place for quite a number of years, which is reviewed annually, which is a tripartite agreement between the Public Health Agency, the Health and Social Care Board and the business service organisations, which outlines the role and responsibilities of each organisation, the resources that they will commit, and also how they will work collectively. So they have a well-rehearsed plan, which they activated, as you've indicated previously, on the 22nd of January with the activation of Health Silver.
Right, and what would that plan actually help them do? Again, was it a structural issue, or would it actually tell them, give them an understanding or an example or an outline of how they should respond in the pandemic?
I mean, a practical example of that is what they did was they, in anticipation of the surge that we were going to see in terms of people presenting with COVID who were acutely unwell, they developed surge plans across a number of specialties. So primary care, secondary care, so that's people requiring hospital care, and across tertiary services, so specialist hospital services, and developed surge plan for health and social care. That's both care homes, social care, mental health facilities, learning disability facilities. So that came together in a surge plan which was published in March. So those are very practical outworkings about how the health service would respond to the pressures of the pandemic. Similarly, there was a plan which was developed in terms of how people would continue to receive emergency care and treatment for individuals presenting with heart attacks, strokes, people who had vascular bleeds, or individuals who had cancer. So those two elements of work, both for COVID and critical, urgent, non-COVID care, was all being coordinated by the Health and Social Care Board, working with the PHA, working with the Health and Social Care Trust and the Ambulance Service.
But those have been developed in the early stages. I'm trying to get at, let's say, the 1st of January 2020. What outline plans were there? Is it simply there was the 2013 influenza pandemic preparedness guide? Was there anything else that would suggest, in the event of a pandemic, this is how you should go about surge plans, this is how you should go about visiting guidance? Is there anything like that?
In terms of those specific elements, in terms of was there guidance on the development of visiting guidance, no. In terms of surge planning, work had been initiated at a UK level around surge planning, and again I responded to this and provided evidence in Module 1 on this issue. Surge plans had been submitted to the department, I understand, although they weren't brought to my attention back in January 2019 for surge planning in relation to an influenza pandemic. Policy colleagues were of the view that they required additional work, and that work was then subsequently undertaken by the Health and Social Care Board with the PHA. So while there hadn't been signed off plans, there had been planning in place for surge planning for pandemic flu. I think it's a separate question whether or not the scale of that surge planning for pandemic flu would ultimately have dealt with what we actually saw with this pandemic.
How helpful was that influenza planning guidance? Did it actually provide you with a great deal of assistance in these early stages in the pandemic response?
Crisis response, emergency response, and again, I've given evidence to this in Module 1, both in the oral hearing and my witness statement, is agnostic in terms of what the particular challenge is. So the structures that you alluded to earlier and that we've covered earlier were extremely effective and useful in applying those arrangements, that command and control, those command and control arrangements, those reporting arrangements, those intelligence gathering arrangements were extremely helpful in the early stages of the pandemic, because those are what we had and those are what we relied on. Those were what we knew. And we weren't starting from scratch, so we did have plans which we adapted. The truth of the matter is that every emergency is different, every epidemic is different, every pandemic is different, and as my lady gave evidence during Module 1, I don't think that the idea that we somehow or other can have a plan on a shelf for every eventuality for pandemic preparedness is the wrong approach. It's about having flexible, adaptable capabilities that we can deploy at pace and at scale for a range of scenarios and a range of potential pathogens, whether those are contact, such as Mpox, which is in the news at the moment, or whether that's transmitted by vector routes, such as Zika virus, or those that are transmitted through the respiratory routes, such as flu and coronavirus.
I'm trying to understand, from the perspective of the initial stages of the response to the pandemic in 2020, whether there were those flexible, adaptable plans on the shelf that can be deployed at pace and at scale, whether those actually existed in Northern Ireland that helped you in the initial stages of the response, or whether they weren't there.
I think I've answered that question, my lady, but maybe I'll, unless I've misunderstood the question. But we did have generic plans. We did have those in place both within the department, within the Health and Social Care Board, PHA, and within the trusts. And we adapted and modified those plans to deal with the coronavirus pandemic.
To what extent, in those early stages, did you consider that decisions should be made on a regional basis as opposed to within each individual trust? And when I say those early stages, I mean late January 2020.
I believe decisions were made on a regional basis. Once the Silver was established on the 22nd of January, that was the role of Silver, is to ensure regional coordination, and that's the role that they fulfilled.
So would it be wrong to suggest that the department would set policy and then it would be up to the trust to implement that policy, and that the department didn't monitor how that policy was being implemented?
That would be wrong, yes.
Because in terms of understanding the impact of the policy that a department has been set, or department has set, it's right that there needs to be a mechanism for which you can review the feedback and you can review the impact of those decisions. Is that right?
Yes.
Do you think in Northern Ireland that there was that sufficient mechanism for the department reviewing that feedback and reviewing the decisions that it taken and the policy decisions that it had set?
And can I seek clarity in terms of what policy are we talking about in normal course of business, or are we talking about policy decisions in relation to the pandemic?
In relation to the pandemic.
There was. I mean, believe there was. I mean, as I've already explained, when we established the Health Gold, which was established on the 27th of January, we were getting regular reports from situation reports from Health Silver, which was advising on escalating issues that needed a strategic decision. And those issues were then being brought to Health Gold, the strategic cell, which I was chairing when not otherwise involved in other responsibilities. And Health Gold was setting the strategic direction, providing leadership to the health service response, but similarly was tasked with providing advice and support to the Minister in terms of other UK considerations, and also providing support to other Northern Ireland government departments. So I'm satisfied that those arrangements were effective and that there was oversight of what was actually happening on the ground, but that came through Health Silver, and obviously it would depend on Health Silver bringing a matter to our attention.
So in general, the department was learning from the impact of the decisions that it had taken?
Yes, I mean, I think back to the starting point of our discussion. Northern Ireland is a very small healthcare system. We are very connected, and during that initial response, that connectivity was a huge strength. So it wasn't just even the formal reporting arrangements that there were through the emergency response plan, but also we were in regular contact and informal contact with leaders within the health and social care system in Northern Ireland.
I want to look at this chronologically, if I can, just to have an understanding of the decisions that were being taken and the information that's available to you at the time. I think this goes back to 22nd of January 2020, where Health Silver was established. On the same day, you offered to meet the Minister to discuss the department's preparation, planning and readiness. And you say in your email to the Minister that day that extensive planning, preparation, liaison was ongoing. What was going on at that time within Northern Ireland?
I mean, again, I have covered this within my statement and the 2C. At that stage, at that time, there was regular for UK nations meetings happening. There was almost daily UK CMO calls where we were sharing intelligence and information as it emerged. The Public Health England, as it was then, later the UK Health and Security Agency, was also hosting four-nation calls with its counterparts, which included the Public Health Agency in Northern Ireland. That had a number of work streams in relation to establishing testing capability and capacity, in relation to planning for first cases, how those would be managed, in terms of communication of those arrangements out to general practice. And there were, at that stage, plans around how the transfer pathways for individuals who, when we detected our first cases. There was also planning going on across government work within the department around making COVID a notifiable disease. We were issuing guidance, specific travel guidance about people returning from certain countries around self-isolation. We were establishing a helpline for individuals who were returning who developed symptoms.
So all of that was happening on and around the 22nd of January, or was this coming later? Because I want to make sure we're doing this chronologically, Professor McBride.
Well, I mean, again, I can't now recall the exact sequence of the timeline, and I would need to refer back to my previous statements in earlier modules.
Well, can I please show you INQ 000 130312? We've got a slightly different display system when it comes to a spreadsheet, but do you recognise this spreadsheet?
I don't think I've seen this spreadsheet before now.
If we can go to the Decisions tab at the bottom. Does that look familiar now? I think that was contained in your evidence proposal, some of these rows.
Yeah, I mean, I'm happy to address any questions on it, but I would not normally have, seen the readouts from the meetings.
Okay, but you're content that this is likely to be the strategic cell readouts comprising details of decisions and actions?
I'm content that that's the case, yeah.
And then if we could please go back to the Actions tab. Thank you. And we can see there that we have 27th of January, and this is action number 2. So this is about high-level cross-government escalation plan. So this is the same day that the emergency response plan was implemented when the Department's Emergency Operations Centre, that's part of Health Gold, was stood up. Is
Yes.
that right? And so effectively, is this where half of Health Gold, the EOC, as I'm going to refer it, that's been activated? The strategic cell, the more decision-making side of things, that hasn't yet been stood up, and that isn't going to be stood up until the 4th of March. Is that right?
That's correct, yes.
So in these early stages, and again, it's not a memory test. If you're not entirely sure, please do say, what responses within Northern Ireland about the healthcare system, as opposed to the general health of the population, how is the healthcare system responding in these early stages in 2020?
Well, certainly from the establishment of the EOC, and certainly we would have been getting daily situation reports. I would have been in the EOC on a daily basis at that time, and any matters that were arising that required to be brought to my attention would have been brought to my attention.
So you were content at that time that the situation within the healthcare system in Northern Ireland was effectively under control?
I would not use the word under control. I mean, I think that we were doing the best that we could in the circumstances that we found ourselves. I don't think under control, I mean, I think is not a term that I would use in the context of the pandemic and what subsequently unfolded. We were taking a methodical and planned approach to the situation as it evolved.
Moving on to the 28th of January.
Do you want to carry on with the end of January, Scott, or it's up to you?
I've got two very different times in front of me. Sorry, I thought it was 7 minutes past rather than quarter past. No, I'm entirely content to break there, my lady. Apologies.
Okay. We shall return at 11:30.
All rise.
Mr. Scott.
Thank you, my lady. Professor McBride, we were just moving on to asymptomatic transmission. We're on the 28th of January 2020 in terms of the chronological flow. It's right that the 4 UK CMOs had a WhatsApp group in 2020.
That's correct, yes.
And I think on there, on the 28th of January, you sent a message to the other CMOs saying that there was evidence consistent with asymptomatic transmission during the incubation period. Do you remember that?
I do remember that, yes. It was in relation to a report of a case that occurred in Germany, as I recall.
What was your understanding about the risk of asymptomatic transmission at that time?
Well, our understanding of asymptomatic transmission was based on what we knew of previous coronaviruses similar to SARS-CoV-2, the causative agents of COVID-19. However, there were obviously clear differences between SARS-CoV-2 and other viruses that cause SARS, for instance, or MERS. But obviously, we didn't have that clarity of information at that time. So I think we were always alert to the possibility that there could possibly be a symptomatic infection. But again, that was something that we didn't have sufficient evidence of at that time. It was something that was actively considered by SAGE and by NERVTAG, the New and Emerging Respiratory Technical Advisory Group. So it really wasn't until I think the NERVTAG meeting of the 13th of May that concerns were flagged about asymptomatic transmission.
But in terms of when you have identified that there is evidence of an issue such as asymptomatic transmission arising from SARS-CoV-2, distinct from any of the other coronaviruses, what was your approach at a time like that? Did you apply a cautious approach in terms of what impact that might have upon the spread within the healthcare system?
I mean, I think if you look at the response to the WhatsApp on that same chain, as I recall, although I don't recall the exact wording, I think the response back from colleagues, and I think it may have been
Professor Chris Whitty.
from Chris Whitty, was possibility of,
yes,
but not evidence of. And I have to say I concurred with that. I was raising the possibility, as I said earlier, that we should be alert to this, but quite correctly, Professor Whitty was flagging that we did not have evidence of this. I mean, I can continue, but
No, but in terms of, so when you have a possibility of something like asymptomatic transmission happening, which is, asymptomatic transmission is going to have a very significant impact upon the spread of a virus in places such as Northern Ireland, is that right?
yes, well, it depends on the several factors. I mean, knowing that asymptomatic transmission occurs is quite separate from knowing to what extent asymptomatic transmission occurs. Mm-hmm. Clearly, if there's an extensive asymptomatic transmission, then you are correct. That is a very significant problem for any jurisdiction, including Northern Ireland. But again, and at that stage, we did not know. And even when we knew that there was, and as mentioned, when NERVTAG said, yes, there is evidence of asymptomatic transmission back, as I recall, in mid-May, we did not then know the extent of that. And it wasn't until there were established studies, both in the health service, the Siren study, and also in the care home sector, the Vivaldi study, that the extent, and actually ONS surveys in the Office of National Statistics in due course, where it became clear the extent of asymptomatic transmission.
But taking a step back, in terms of a protective approach, a cautious approach, the protective principle, however you want to frame it, when it came to the early stages of a pandemic, how did you approach that concept of a cautious approach to new and developing evidence in response to SARS-CoV-2?
Well, I think the general approach that we took, both at a population level, in relation to the decisions by ministers to initiate the social distancing, the advice to limit social contacts, the subsequent lockdown.
Sorry, I should specify, in terms of how healthcare systems should respond.
Well, I was going to go on to that, and the measures that we then put in place in parallel with that. So the social distancing measures that we put in place in the health service, one-way systems, social distancing in waiting areas, moving to remote consultations, all of those interventions were basically put in place because obviously there was the possibility of asymptomatic transmission. So while we didn't have evidence of it, my point I'm making is that we acted in a precautionary way because we couldn't be absolutely certain that it wasn't occurring. But as I say, if it was, we did not know the extent of it. And equally, we did not know at that time that whether for instance, if we suppressed all symptomatic transmission, that asymptomatic transmission itself would be sufficient to continue to drive the pandemic. So there were lots of unknowns.
Leaving asymptomatic transmission aside, just in terms of applying a precautionary, you say the precautionary way that you acted, was that the general approach that you would apply? You would act in a precautionary way when there was uncertainty of the evidence?
I think that was the general approach that we adopted, and we obviously reviewed on an ongoing basis the measures that we had in place, the advice that we were providing, and updating that as new evidence emerged.
And while we're talking about the CMO WhatsApp group, what was the level of engagement like between the CMOs during the course of the pandemic?
In those early days, practically daily, often twice daily, every day, at weekends. We often had early morning calls, late evening calls. I think one of the strengths of the response to the pandemic was that very close engagement that we had. We all came from different professional backgrounds. We had different ranges of expertise. We had, prior to the pandemic, very effective professional working relationships, and that was a real asset during the pandemic response.
Was it a free and full exchange of information, thoughts, ideas between the four of you?
Yes, and I think I've addressed that in my evidence to M2C. There was as I say, we all came from different professional backgrounds within medicine. There was discussion, there was challenge, views were sought, views were conveyed, and I can't, in the main, and I'm now struggling to think of any occasions when there was a significant difference of consensus professional view amongst us.
When there were, this is a question I've been asked by one of the CPs to ask, when there were proposed divergences in guidance for healthcare systems between the various devolved administrations of England, were those discussed in advance of implementation by the CMOs or not?
I missed the start, but I think it was about divergence in guidance, was it?
Yeah. If the different healthcare systems were going to do different things, did the CMOs talk about it ahead of time?
Well, obviously policy decisions are for ministers, and we cannot, in advance of ministers' policy decisions, determine what ministers decide. But we would have made each other aware of advice that would have been put to ministers. So there was a level of awareness, but what we didn't do, what we couldn't have and didn't have was advance warning of ministerial decisions, because those were the prerogative of ministers.
And one of the other questions I've been asked to ask is, are there any lessons that can be learned in respect of communication between the four CMOs for any future pandemic?
It's essential. It's vital. You mentioned earlier about, what was it like? What was your average day like? I think that we were a huge source of professional support to each other. I think the combination brought huge strengths. I hope that the advice that we provided to respective ministers and respective jurisdictions benefited from that. And also, it was a great sense of personal support as well, which was absolutely vital. Yeah.
Stepping back into the timeline, so I just want to move to the 4th of February 2020. At this point, there's 0 cases in Northern Ireland. Is that correct?
Yes, the first case was the 27th, yeah.
And so at that time, you were seeking to arrange a meeting with PHA and HSCB about reasonable worst-case scenario pandemic flu surge planning. So that had been just over a week since the EOC had been activated. Why is it that there'd been that week gap before you then start to consider surge planning?
Well, the work had already commenced. It wasn't that I was considering surge planning. The work had already commenced by the Health and Social Care Board and the PHA. The purpose of my meeting was to seek assurance on the progress of that work. I subsequently attended a meeting with colleagues from the Health and Social Care Board and the PHA on the 11th of February.
Yes.
They advised me at that meeting that the work had already started and commenced. There already had been communication out to health and social care trusts, and they were already beginning the surge planning. So it wasn't that my meeting was initiating that. What I was doing was seeking assurance that progress was being made on that surge planning.
And we'll come on to the 17th of February where those plans have been provided to you
Sure.
and your response to those. But also on the 4th of February, it's referenced about HSIDs, high consequence infectious diseases. It's right that there are no HSID beds in Northern Ireland.
That's correct, yeah.
And so what PHA was seeking to do is they were seeking to determine the number of HSID beds available in the Republic of Ireland.
Yes.
Is that correct? In the early stages of a pandemic, where a pathogen's been declared as an HSID, what happens in Northern Ireland, given that there are no HSIDs?
Well, the arrangements are that there are, I mean, as you know, there are only a small number of high consequence infectious disease beds across the UK, I think some 30 in total. They are not designed to deal with large-scale epidemics or pandemics. Obviously, their numbers, they cannot. They are there for to deal with the rare cases of imported disease that we do see in the UK, such as some of the hemorrhagic fevers, Lassa fever, for instance. There are a set of criteria, there's 6 criteria in total.
I understand how they operate. It's about how Northern Ireland deals
Sure.
with those cases.
So in the situations where a case that's classified as a high consequence infectious diseases, there is an arrangement for transfer for those patients to other parts of the UK, to the beds that exist in the rest of the United Kingdom. Unfortunately, there are no HCID beds either, HCID beds in the Republic of Ireland. So that does present some particular geographical challenges.
The sea, is that correct?
Sorry?
The sea.
Yes.
Geographical
Yes.
challenges.
I mean, as an alternative, what the PHA was doing at that stage was, as well as working with the Health and Social Care Board around the transfer arrangements, was again working with the Regional Infectious Diseases Unit in the Belfast Trust to develop pathways for any individuals that couldn't be transferred to an HCID unit in the rest of the UK to be managed within the Regional Infectious Disease Unit within the Belfast Trust.
And I think it's right that actually the first case in Northern Ireland wasn't able to be transferred to England.
That is correct, yes, and that case was managed in the Regional Infectious Disease Centre in the Belfast Trust.
In the event of the early stages of a future pandemic, would the same situation arise in Northern Ireland? You have an early case and actually the transfer routes aren't open to transfer somebody to England. Would it be the infectious diseases ward, I think it's 7A within the Belfast Trust? Is that what would apply?
It is correct, it is 7-day, and as I say, as a fail-safe, if indeed those transfer arrangements were not possible, then the individual would be managed in the specialist infectious disease unit in the Belfast Trust, correct?
So I'm not following 7-day?
7A, it's just the ward.
Oh, I see.
It's my lady, it's level 7 in the Belfast City Hospital, and it's a specialist unit within that, or specialist beds within the unit.
Thank you.
Because in terms of, just very briefly on this point, in terms of the transfer, there are existing, I think it's private transfer arrangements, isn't it? And effectively they're not intended to function very well in the course of a pandemic and transporting somebody who has what has been classified at that time as a highly contagious infectious disease. Is that correct?
Yes, those responsibilities fall within the remit of the Health and Social Care Board and the relevant policy team within the department. And you're correct, there are particular challenges with the transfer of patients, particularly with private providers. During the pandemic, some special arrangements were put in place by the Health and Social Care Board, and I think those are covered in my statement.
Yes. I'm going to move on from that topic and come back to the surge plans. I think we were talking about the 17th of April.
February.
Thank you for correcting me. So, as you say, this is 17th of February, this is the tail end of almost 2 weeks since you'd had the meeting with PHA and HSCB. So surge planning had been going on for longer than that at this stage. And an iteration of that surge plan was provided to you, and you say that you considered that that initial iteration was not acceptable. If I can please have on the screen INQ 000421784, that's page 142, paragraph 223. This is your statement. And if we can just go up to the one above in relation to critical care. Focus of the surge plan was based on the Nightingale. There were some inconsistencies in the local escalation stages. What do you mean by there were some inconsistencies?
Basically, back to your earlier questions about the regional approach, there were, when I reviewed the plans, I recall, and I can't recall the detail given the passage of time, there was inconsistencies in terms of decision making about escalation. So how beds, bed capacity would be increased, and that differed across the various plans that I considered. Now, to ensure equitable access, which is crucially important, given the anticipated pressures, there needed to be a commonality of approach across how and when those additional beds would be escalated, and particularly also in relation how those beds would be staffed. Because in all likelihood, what we were anticipating was there would be significant pressure on healthcare workers, on nursing staff, on physiotherapists, allied health professionals, doctors working in intensive care. So there needed to be, to my mind, those plans needed to be all interconnected, and also there needed to be a regional plan as to when and how we would activate a Nightingale facility. And as I looked at the plans at that time, I felt that more work was needed.
Yes, and I think just in terms of the third bullet point in relation to secondary care, so the plan had each trust had a local level plan. All plans needed to connect at a regional level to ensure regional consistency, and it had to connect the total system of health and social care, because I think you were well aware at that point in time in Northern Ireland that you were going to require all trusts to effectively contribute towards the Nightingale, because there wasn't capacity just within one trust to cope with it. Is that correct?
Yes, and I think it's back to my earlier point about that, the response to the pandemic required in all a single system response. And what I was seeking to do was basically to ensure that that there was a Northern Ireland HSC response, which ensured that everyone had access to the care that they needed, and that there was equitable access to care, and that as best we could, that we provided care for those patients who were acutely unwell with COVID, while continuing to maintain services for those who required emergency or time-critical treatment for their conditions.
And effectively, that could only come through the department, that regional level. Is that correct?
Well, no. The role of the HSCB, PHA, BSO at Silver is to ensure regional coordination. The department sets strategic direction. That's what I was doing in terms of setting strategic direction, chairing Health Gold. Yes. But it's the role of Health Silver to ensure that regional coordination. And what I was pointing out here was that I felt there was further work to be done in ensuring that regional coordination. I would add one caveat, I might add, which is important, that it was difficult and challenging for the Health and Social Care Board, the PHA and health trusts to plan for the range of eventuality that might occur, because at that time our modelling that we had in terms of what those pressures might be was not as advanced as it became then later in the pandemic. So they were dealing with a significant deal of uncertainty and planning in the context of that uncertainty.
In terms of that modelling, it wasn't Northern Irish modelling at that point in time, that was modelling conducted by SAGE.
That's correct, yes.
And because you're talking there about setting strategic, if you're talking about surge planning across the entirety of Northern Ireland, that is a strategic decision, correct?
It's a tactical, strategic decision. I make that distinction because it is an important distinction. The principle of subsidiarity within any crisis response is crucial. If it isn't abided by, what happens is that if all decisions have to be made from the department, it paralyses the rest of the system. So it has to be only those matters which are important to be elevated to the department for either a policy decision, a strategic decision, but that regional layer, the coordination of the regional response, as is outlined in the emergency response plan, is the responsibility of Health Silver, working with Health Bronze. And simply what I was indicating to Health Silver, which is the responsibility of Health Gold, was I was testing on behalf of Health Gold in the department those plans and basically requesting further work.
So if you had signed off on those plans at that time, that you thought those plans were significant, what would have happened? They had been adopted then and there?
Well, I've no doubt, as happened anyway, those plans would have been modified as time went on because...
But at the time they were presented to you then, rather than later?
I mean, when those plans were presented, I think there was a subsequent workshop which was held by the Health and Social Care Board on the 5th of March. So there was an ongoing process of refinement of those plans. So what we received at that point in time was still very much in development. And that was right because as our knowledge developed and as we developed more information from the modelling about where those pressures would be, the numbers of people, for instance, who would require admission, the number who would require oxygen, the number that would require critical care admission, then those plans were constantly refined. So there wasn't a point in time where we said, this is the plan, we're going to stick to it. These plans were constantly refined because they needed to be constantly refined.
But this early stage in late February, you hadn't stood up the strategic cell, that's correct? That was a
That's correct, yes.
But surge planning is essential in terms of a strategic overview level because you are talking about what services you are going to effectively not be able to provide, how you're going to redeploy.
Yeah.
That is a very high-level decision. So can you explain why these discussions were taking place in late February, but the strategic cell was not yet in place at that time?
There was, I mean, as I said in answer to an earlier question, there was a high level of connection between all parts of the service at this stage. When we stand up Health Gold, which we did in early March, that puts in place an additional set of requirements on Health Silver and on Health Bronze and reporting arrangements. What I was satisfied was happening at that time, prior to the activation of Health Gold, was there was active surge planning going on within the health and social care system. I had sought assurances on that. I had met with the Chief Executive of the Health and Social Care Board, the Public Health Agency and their team on the 11th of February and was assured that work was ongoing. Here we're seeing the outworkings of that, and I commissioned further work based on that. So I think the point I would make is that strategic oversight, that policy direction was being clearly communicated, was being understood and was being acted on by colleagues at Health Silver.
So even if the strategic cell wasn't there, it made no difference?
The Health Gold serves an important purpose and role.
So I'll just focus on strategic cell because half of Health Gold, the Emergency Operations Centre, had been up since January.
That's correct.
So it's the second part, that strategic decision making, that I'm trying to focus on.
Yeah. What I'm saying is that even before the activation of Health Gold, that strategic oversight was being provided prior to the activation of Health Gold. I think we've just given a good example where I was working with colleagues, policy colleagues within the department, within secondary care, health policy group, again, actively considering the surge planning. We hadn't, yes, you're correct, activated the strategic cell at that point in time, but that strategic oversight, strategic consideration was already in play at that time.
So was it, by the way, that document come down now, thank you. Just in terms of that thread of activation of the strategic cell, that happened on the 4th of March. Did that happen because that was the day that the first suspected cases arrived in Northern Ireland?
No, the first confirmed case in Northern Ireland was the 27th of February.
So why hadn't the strategic cell been stood up when the cases had arrived in Northern Ireland?
Well, it was the first case. I mean, I think that the emergency response plan is designed to be modular. And as we covered earlier, bronze can be set up without health silver being set up. So, for instance, if an incident is at a single trust level, then health bronze will address that. If an incident is occurring across several trusts, then health silver is activated. And the health gold is designed to be modular as well. So the emergency operations cell, as you mentioned earlier, was activated on the 27th of January, following the activation of health silver. So again, reports that were being generated by the EOS, by health silver, were already being received by the department. The department already had oversight of those. So it doesn't and didn't require the health gold, in my judgment, to be activated on the 27th of January. We did activate it on the 4th of March, and in my view, it is always a judgment call, but in my view, that was a proportionate and appropriate time to activate it, because once you activate health gold, basically what it means is that the department effectually stops all other activity. It reverts into business continuity arrangements. It generates its own work in terms of the demands it places on the system. And the balance has to be between planning and preparation and providing health silver and bronze with the headspace and room to get on and do the planning and preparation, as opposed to the department activating health gold and asking for twice daily situation reports in terms of what's going on the ground. So I was satisfied at that stage that there was significant awareness and intelligence of what was going on in the system, that we had mechanisms for matters to be escalated through the EOC and the department, that those could be brought to my attention or other policy leads within the department. And in my judgment, the activation of the strategic cell was both timely and appropriate when it was activated in early March.
Okay, and we want to pick up that thread in terms of the information that's available to you. If we can have up on the screen INQ 000 430 391. Do you recognise this document? I believe it's a dashboard that was provided by the Department of Health.
Yes, I think this is the COVID-19 dashboard that was developed, yes.
Yes. And then you can see in the top left corner, PHE. Had this come from PHE? And then may have been adapted by Northern Ireland?
Oh, sorry, apologies. Yes, this is a PHE document, sorry.
But then this is the information from Northern Ireland. And then if we can just scroll down on column A, it appears that the types of data that are highlighted in orange or yellow, I can't quite tell the difference, are the ones that the information has been kept, but the ones in white is not recorded on this dashboard. There are some there, we can see, for example, staff absences, staff illness, staff deaths, PPE stock. Let's leave aside the PPE stock, but in terms of staff absences and staff illness, was that information being recorded in Northern Ireland?
Sorry, I'm not sure what time is this document?
Well, we can see there that this is the 1st of March. You can see from column E. And then if we go up to the top row, please, you can see there that deaths by setting, cases by age group, that's all there from the 1st of March.
Okay, and firstly, I mean, information on staff absences doesn't fall within my professional or policy remit. The responsibility for and the recording of staff absences is a core responsibility of the employer, i.e. the Health and Social Care trusts. But it was not something that that certainly at, as I say, that at that stage that I was responsible for, or that was being information that was being fed to myself.
In a pandemic where you're talking about surge planning, how you're going to provide the capacity, particularly in the situation that Northern Ireland finds itself with its lack of resilience, I think is using your words. Did you not need to know information such as staff absences, staff illness, staff deaths?
Well, that information, there was an HR cell within the strategic cell, which was, we've already established was put in place in early March. That cell, through Health Silver, from the trusts, would have been collating that information. And as I've made clear in my evidence and witness statement to 2C and in this statement, that principle of subsidiarity would arise. So the chairs of the individual policy cells within the strategic cell were all policy leads within the department. They would have been dealing with and addressing issues such as concerns around HR, human resource issues, staff absences, occupational health advice, etc. So those matters would have been considered within those policy cells and would be brought to my attention as chair of Health Gold as necessary. But given the division of responsibilities that I had at that time, it would not have been humanly possible for me to be, or indeed appropriate for me to be across all of the detail of the work that was being undertaken by those 13 policy cells within the strategic cell.
So trying to cut through this a little bit, staff absences were being recorded.
They were, yes.
And that information was available to the strategic cell, even if it wasn't necessarily on your desk.
Yes.
Put it that way. And so you would have been informed if there had been specific staff absences in any certain area, if it was necessary.
If it was necessary, I mean, it would have been a matter of which the HR policy cell would have dealt with.
Okay. Wouldn't you need to know about every single staff death from a pandemic?
That is a matter that, yes, the Minister was very keen that the department was made aware of. He asked me as Chair of Health Gold to write to the trusts in Northern Ireland, which I did, as I recall, in early May, just to make absolutely certain that information was being recorded. And I understand that information was, and I can recall that information being reported on a daily basis in relation to staff who had acquired COVID and any deaths from COVID in staff employed by the health service.
So even if it's not on that dashboard, each staff death was being recorded within the department?
Well, it was being reported to the department. I understand in communication, which has now been relayed to the inquiry, that information wasn't necessarily collated, but it was being reported on a daily basis into the department and into the HR policy cell.
Do you think it should have been collated on reflection?
I absolutely do think it should have been collated, and I understand that the department has advised that it did not validate that information to ensure that all trusts forwarded the information, but I absolutely do believe that it should have been validated, verified and collated. I mean, there is a statutory requirement on trusts under the on the RIDOR regulations. So risk of diseases. Sorry, apologies, I've forgotten the exact name of the acronym.
Don't worry about it. Let's use the acronym.
To actually report such occurrences. So that isn't just. I mean, that is a statutory requirement.
But isn't it more than that, more fundamental than that? As the Chief Medical Officer, didn't you want to know about the staff within HSE who died as a result of the pandemic?
I mean, of course, as Chief Medical Officer, I would wish to know. But again, as I said earlier, those responsibilities, those professional policy responsibilities did not fall directly within my remit. There were many, many demands and many responsibilities that I had in the pandemic. I had to rely on others to fill their responsibilities during the pandemic. As I said earlier, I could not be everywhere. I could not be across every detail. And indeed, that in itself would have not been effective in terms of the wider pandemic response, and indeed would have been disempowering to those who were more knowledgeable in the area than I was.
Looking at the data that the department was actually keeping during the course of the pandemic, was it keeping information such as the number of hospitals who were closing emergency departments? Because we have a statement from the Department of Health setting out the data that was held, and the response often was, you need to ask the trusts. Was there not that central repository of information within the department to help it understand precisely what was the picture on the ground in Northern Ireland?
Again, there was a COVID-19 surge directorate which would have been working with Health Silver in relation to that. I mean, I would have expected that information to certainly be held at Health Silver. But as I say, again, I was chairing the strategic cell. But again, I had to delegate those responsibilities to the relevant policy leads within Health Policy Group who were leading on secondary care. Such was the nature of the response required that principle of subsidiarity and everyone leading on what they were knowledgeable on was absolutely crucially important. It would just not have been feasible or possible for me to be across that level of detail. But certainly that level of detail would have been held and certainly known by trusts who would have informed Health Silver and the relevant policy cells within the department would have been briefed on that. And certainly that briefing would have been brought to the Minister's attention if it was necessary.
Are you satisfied that you, as CMO, as Chair of Health Gold, had the sufficient information and data available to you that you needed to perform that role?
I think, looking back, I think that the availability of data was, I think, one area of learning for future pandemics. I think that and that applies across so many areas, and the ability to link that data. And there were challenges with data. There were challenges, in relation to the development of the dashboard and testing data. There were challenges in relation to monitoring PPE supplies. There were challenges across so many areas. I think that was a reflection of the unprecedented circumstances that we found ourselves in and the unprecedented challenges that the pandemic presented. There was much more information that I would have liked to have at my disposal than I did have. However, as chair of Health Gold, we had to work with what we had and then develop what we needed, and we took that approach throughout the pandemic.
Let's deal with specifics. Was there any information that you needed that you didn't have access to, that to your mind caused a significant detriment to your role?
In terms of a significant detriment,
I'm trying to take it above the generality about things that you thought were actually important or key pieces of data that you were missing.
I think there were, for instance, there was, in the early days, there was difficulty in collating information around clusters and outbreaks, for instance. And that was a challenge, which was addressed. In the early part of the pandemic, prior to the establishment and the work that I commissioned to establish the COVID-19 dashboard, we did not have the ability to present that information in the public domain around the number of people who were testing positive, the number of people who were in hospital, the number of people who were in intensive care. That was
when
re-
you say ability to present that information, present it to who? Do you mean for you to understand it?
No. In a public-facing way, and I think
I'm not so concerned, Professor McBride, about the public facing. I'm interested about the impact upon your role.
Okay. Well, maybe we can come back to the public-facing data, because I think that's really important in terms of bringing the public with us, given the ask that we were making of them. I think that the information around clusters and outbreaks was certainly a source of frustration to me early in the pandemic, and colleagues in the PHA did put in place arrangements to collate that information, and we did provide that information on a weekly basis to the executive to inform decisions around NPIs and to inform engagement with local government and the various sectors where we were seeing clusters and outbreaks. So that was one issue. Certainly we encountered challenges early on in the pandemic in relation to the reporting of deaths and the explaining the differences between how we were recording deaths using the approach about individuals who had tested positive within the last 28 days, whether they had died of COVID or not, versus the official statistics from the Northern Ireland Statistical Research Agency. The Minister was very keen, and we needed to have access to the place of death, and that was something which was put in place in due course by NISRA. I think that there were also significant data challenges in relation to the recording of certain characteristics, such as ethnicity, such as disability, in relation to the data that was accessible to me. That was problematic and challenging.
Can I just talk specifically about ethnicity? Because I think that you raise in your report, in your statement, if we can have INQ 000421784, it's page 247, paragraph 424. As you say, ethnic minorities form a much smaller proportion of the population than in many other regions of the UK, and ethnicity is not well coded in NI healthcare records. As a consequence, analysis regarding ethnic minorities was not available due to the poor coding of ethnicity in healthcare records. It was not possible to look at trends in those from different ethnic backgrounds, nor to analyse impacts. Was that not an issue that had been foreseen ahead of a pandemic, that there was poor ethnicity coding in the various records?
Well, again, it wouldn't have been an area that fell within my professional or policy remit, but certainly it was an issue right across the public sector and government that had been recognised in the Racial Equality Report, which was published in 2015 by the Executive Office, that ethnic coding across departments and their arm's length bodies, public services, was not uniform, and there were gaps, and there was a commitment to improve that. Now, within the healthcare systems, there are, one can record ethnicity, but there is not uniform recording of ethnicity, and that is something that clearly does need to be improved.
When you were as part of your response to the pandemic, you would have become aware of the disproportionate impact of COVID-19 on black and minority ethnic workers in particular. Is that right?
Yes.
And so I presume that you would have wanted to look at the data and to say, how is this impact playing out in Northern Ireland? Did you do that?
I couldn't do that because I didn't have the data to do that. As I say, absolutely would have wished to do that, but because of the lack of data, that was not possible.
What was done to improve that situation?
There was, during the middle of the pandemic, I mean, again, it was not something that fell within my direct remit and responsibility. There has been work that's been taken forward by the department since that, in terms of the department is represented by the Health and Social Care System in the cross-departmental working group, which is looking at securing more uniformity and better ethnic monitoring in Northern Ireland.
Sorry, can I just clarify? They're still looking at it.
That's what I understand. I'm not directly involved in the work, and I don't have any responsibility for that. But it is something that needs to be improved and significantly improved.
Okay. Can I just take you back to it's an action in that log that came out of health. So it's INQ 000130312, and it's in the action sheet, and it's reference 817. Apologies, this is going to require scrolling down. It's quite a long way down. Apologies, my lady, we don't quite have the same technological abilities to manage spreadsheets as we do other documents. Thank you. Apologies, I have a different reference. I will come back to that reference, Professor McBride. I don't want to disrupt the flow, but it's in relation to, are you aware that whether there are any discussions about whether recording of ethnicity was a GDPR issue?
Again, that's out with my professional area of knowledge and competence, so I can't answer that question.
Okay.
So when did it become obvious in Northern Ireland that ethnicity might be having, those from an ethnic minority background might be suffering a disproportionate impact?
There was work commissioned by Professor Chris Whitty, which I think it was back in April around 2020, and there was a report published in 2020. One of our deputy chief medical officers, Dr. Naresh Chadha, was a member of that group. We could not, and in the middle of the pandemic, it was just not possible, given the other demands that there were, for us to work to modify the systems to extract that information, given the many other demands that there were. But certainly what we did was we took significant measures to try and address that. And I mean, I can give 2 examples if that's...
Well, really what I wanted to ask you was, so you became aware from a report in April 2020.
Yeah.
We're now September 24, and as Mr. Scott suggested by his tone when he said still, we still don't have any changes to ensure that you can record ethnicity where there's a disproportionate impact?
Well, my lady, I can't advise on the work, and that's why I'm very hesitant to answer this. I cannot advise that of the work that's been taken forward by others with policy responsibility for that, and I can't answer to the cross-departmental working group, which I'm not a member of, in terms of what progress has been made on ethnic minority monitoring. It was a commitment within the 2015, I think it was published in 2015, racial equality strategy to improve monitoring, but I cannot advise you in terms of what progress that's been taken forward.
2015?
I think that's the date of the publication.
I thought at the beginning, when Mr. Scott was asking you about your role in the Department of Health, you're part of the top management group. I mean, is this not an issue that's come to the attention of those on the top management group?
I've not been involved in any discussions where that's been raised at top management group.
Who would we need to ask?
I beg your pardon?
Who would we need to ask?
Who would you need to? I suspect probably the executive office in terms of who I believe, and I may be incorrect, have responsibility for the racial equality strategy, and perhaps an update in relation to the work of the cross-departmental group, which I understand has representatives from all government departments and other agencies.
I think we'll be hearing from Mr. Swan, won't we, Mr. Scott? Can we make sure that those who are advising him and the department are aware of my concern about this issue?
Yes, my lady. In terms of the timings, I'm very grateful for the assistance I've received in finding the references that I'm looking for. There is row 918. It's reference 889. It's dated the 15th of June 2020. Considerations required from the SIRO. I presume that's an information officer of some description. This is a GDPR issue for the recording of ethnicity and nationality of people admitted with COVID in order to establish that there is disproportionate impact on Black and Asian and minority ethnic communities and to support the targeting of health protection messages. Consideration should be given to recording the ethnicity and nationality of people admitted with COVID. Again, is it the same answer that you don't know what the outworkings were of that suggestion on the 15th of June?
No, I mean, I do note that it's indicated that it's closed, but I don't know what that indication of being closed means, whether it was actioned and what other ongoing work there is. I mean, I should say that, you know, we did do significant work in Northern Ireland looking at inequalities, but that was, you know, looking at sex, you know, deprivation, etc. But we could not do any specific work on ethnicity. The NISRA, the Northern Ireland Statistical Research Agency, did some work and did publish a report in August 2020, where it used, as I recall, country of origin as a proxy for our ethnicity. Now, that's far from satisfactory, and that report was published in August 2020. I think there was very, very limited analysis, as I recall, that could be carried out in that report because of the very small numbers of deaths that had occurred across the various ethnic minority groups. So again, it was a very unsatisfactory piece of analysis.
Just one final point in terms of whose responsibility this is. I think it is your statement that says ethnicity is not well coded in Northern Ireland healthcare records. That's not an executive decision, is it? That's a Department of Health decision.
That is a Department of Health decision. I mean, there is, I mentioned earlier that the department has progressed work around the rollout, and I think I've addressed this in my statement around an electronic patient care record. There is the facility to record ethnicity within that. It is not well recorded at this point in time. The department has also recently published a data strategy and with the indication that it will develop a data institute. But those are areas that, again, are out with my direct responsibilities as Chief Medical Officer.
Okay. So coming back into what is within your remit as Chief Medical Officer, so the first meeting of the strategic cell was on the 9th of March 2020. Is that correct?
That's correct.
And again, looking at that log, which we don't need to bring back up, I think topics that were discussed about Silver requesting an urgent decision about the early suspension of elective non-urgent procedures to commence on the 16th of March. You're looking for guidance required for immune-compromised, and that was to be raised at a cross-government call. And Silver was asked what guidance on visitors to hospitals available in relation to reducing footfalls in hospitals. So you're looking there at effectively shielding, visiting, and suspending care. Is that 9th of March effectively where we see the strategic cell really start to take grasp of how the healthcare system responded in Northern Ireland?
Well, I think we see a very clearly outlined systematic approach. I mean, I wouldn't say that we hadn't taken grasp prior to that date, if that's the inference in the question.
It was the strategic cell taking grasp rather than anything else.
Yeah, I mean, I think that, you know, the department was fully aware of the work and planning preparation that was going on within the wider the wider health and social care system prior to that date. But yes, in terms of that systematic, I suppose, approach, the establishment of the relevant policy cells, the turning down of effectively all departmental business, effectively the department going into business continuity planning arrangements and effectively stopping everything else. But COVID, yes, that is the date.
And I think it's right that there were around 15 cases or so on that 9th of March.
I cannot recall.
If you take it from me that that's what's contained in that dashboard, there are 15 cases on the 9th of March. So there may not be many cases in Northern Ireland, but presumably you were looking at what was happening in England, what had been happening in Italy, what had been happening across the world, and how quickly these issues can spread.
Yes. Yeah.
So is it not a little late on the 9th of March for the strategic cell to be dealing with urgent decisions about suspending elective care, shielding, guidance, and visitation?
I mean, we would not want to suspend elective care prematurely. I mean, the suspension of elective care or reducing elective care has very fundamental and serious consequences for the population in Northern Ireland. So we did it when it was necessary and appropriate to do so to ensure that we were able to balance the need for people requiring hospital care with COVID. I mean, as I recall, the first admission to intensive care in Northern Ireland was not until the 15th of March. So it would have been disproportionate and, in my view, inappropriate to downturn elective care prematurely, given the very significant consequences that it would have for the population in Northern Ireland.
Yes, but in terms of completing your plan for preventing elective surgery, should that have been done at an early stage compared to the 9th of March? Because there's a difference between when your plan is complete to when you then implement that plan.
Well, the plan, I mean, the ongoing work on the plan resulted in the publication of the plan on the 19th of March. And that included a comprehensive plan across 21 service areas in terms of surge planning. And it was published, to say, on that date. And that was the outworkings of the work that had been going on from February. And that plan was subsequently revised and updated. There was also a subsequent document which was published sometime later, which was the outworkings of intensive engagement and with the Health and Social Care Service about protecting critical services during COVID. So throughout all of this time, this was an iterative and ongoing process, and I think it is absolutely wrong to suggest that it was only when the strategic cell was established in the first meeting of the 9th of March that this all started to happen or started to be coordinated. The emergency response and the planning and preparation that was underway continued, and it didn't require the strategic cell necessarily to be activated for that to occur. And you can see that the engagement and the direct engagement that I was having with colleagues within the Health and Social Care Board and the PHA in early and mid-February, I think, is evidence of that.
So did the strategic cell provide any benefit then on the 9th of March?
I'm not saying that it didn't provide benefit. I'm saying that it was activated at a time when we recognised that there was a need at that stage for more strategic coordination at the policy level, because the strategic cell fulfills several functions. Its role is to provide strategic leadership and coordination to Health Silver. It's also to ensure the support to the Health Minister. It's also there to provide support to other government departments, which we'd already been doing in any event in terms of their planning and preparation and briefing, but also to ensure that the Minister is supported in providing feeding into the wider UK response. So there are very many elements to the roles and responsibility of the strategic cell.
Okay. You were talking there about the wider UK response. Let's look at one of those. So your statement says that on the 15th of March, Professor Chris Whitty circulated a note on shielding, and that note reflected discussions between the 4 CMOs. What discussions had there been between the 4 of you about the benefit or whether shielding should be introduced?
The details of this I don't now recall, given the passage of time, but essentially the broad context of the discussions were that we had a new pathogen which the population had no prior exposure to. There was no pre-existing immunity. There was no treatment available. There were no vaccines available, and the likelihood and timeline for treatments and vaccines being available may well be a year or more. So there was no realistic possibility or probability of effective medical countermeasures at that time. And we discussed firstly, and in that context, we discussed the emerging, and it was only emergent information at that stage about those who were most at risk of severe disease. And as I said earlier, we gained much of that information from those countries that were further ahead of us in the pandemic. And the overall policy approach was that in those circumstances, new virus, no pre-existing immunity, that we needed to protect those who appeared from the emerging evidence were at greatest risk. And that informed the policy on shielding. And that was the sort of the broad context of the discussions that we were held.
And what was your view on the benefits and the risks of implementing shielding?
I think we were all acutely aware of the significant negative impacts of it. I mean, we did say at the time that the policy was announced, and I recall saying this during some of the media briefings at the stage, that this was about protecting the vulnerable from the virus, but it wasn't about removing the vulnerable from society. Because we were very, very acutely aware of the very negative impacts that, effectively advising people to limit their social contacts, to stay at home, to not to go out into public places, for those caring for them or living with them to take such a precautionary approach would have profound social, psychological and mental health consequences. And we were very, very mindful of it. So it was a very, very difficult judgment in terms of trying to strike that right balance. But in the consequences, as I've said, with no immunity and a new virus that was clearly causing very severe disease in some people, it was the only course of action that was available to us at that time.
So there were no alternatives?
Well, I mean, were there any alternatives? I mean, I would just say we did several things in parallel.
Well, you did. Your final line of your sentence was, it was the only course of actions available to us at the time.
Well, I do say later on in the statement, when in terms of, yes, only available course of action to us at the time in the context of the individuals who were extremely clinically vulnerable. But clearly the best approach to protecting those who are clinically extremely vulnerable is to suppress the transmission of the virus in the community. And we had that sort of two-headed approach. We were, at that time also, had provided general population advice around social distancing, reducing contacts. And that had, prior to the decision on the first lockdown on the 23rd of March. So we were taking efforts using non-pharmaceutical interventions to reduce community transmission, because we knew and always knew that keeping community transmission down was actually the most effective way of protecting the vulnerable. But the difficulty was that the only way, we always also knew that the only way out of this pandemic was with medical countermeasures, with treatments and vaccines, as I've said earlier, and that was unfortunately an indeterminate period in the future.
How did you plan to measure, and I'd say this is you personally, how did you plan to measure whether shielding as a concept was working?
Well, I think I've covered this again in my statement. I mean, I think it's very difficult now to assess the effectiveness of shielding in terms of, I mean, it depended on individuals following the shielding advice as best they could, and recognising this was really, really difficult. It was very difficult for those who were asked to shield, and indeed on their family and on their carers. But we didn't do any sort of real-time assessment of its effectiveness, and indeed it would be difficult now to do any retrospective assessment of its effectiveness given the sort of universal application of it at that time. I mean, certainly what I did do, however, was in May, 27th of May, I did commission the Patient Client Council in Northern Ireland to do research, to hear the views of people who had been shielding, because
that impacted upon the decision to pause shielding at the end of July. But the decision to impose shielding, you must have gone into it with an understanding of this isn't going to be forever. We need to have a mechanism for when it's going to end. How did you measure the point, or how did you anticipate that you would measure the point at which it should end?
I mean, the shielding, by its nature, it was a broad brush approach. It's not it wasn't an exact science. We didn't have all the information and data that we needed. We didn't have all the knowledge that we needed. And, as the policy on shielding evolved, there were groups that were added to it later as evidence occurred around their susceptibility, individuals living with Down syndrome, individuals with stage 5 kidney disease, etc.
Forgive me, Professor McBride, it's not quite answering the question about at the time that shielding was introduced, about as opposed to when aspects were added on later.
Well, the answer to the question is that whenever levels of community transmission were at a level where we felt that the advice on shielding could reasonably be relaxed, and or until such times as we saw significant changes in population behaviour to protect those who were most vulnerable. And I think, as we all know and can look back now and experience, there were the population at large was extremely altruistic in terms of the steps that it took to protect the vulnerable in society. It's hard to imagine, coming here this morning on the tube, that not so very long ago we were all wearing face coverings, we were all social distancing, we were all in one-way systems and shops. So children suffered hugely because of the impact on their education. So there were steps that we as a society took to protect others that were vulnerable, and that made a safer environment for those who were shielding. I mean, in Northern Ireland, for instance, in February 21, as we were relaxing further the shielding advice, we introduced a distance aware scheme similar to a scheme in Wales, because we'd heard from people who were shielding that they were previously been shielding that they were concerned that the rest of the population had relaxed too much, that they weren't respecting social distancing and some of or indeed wearing of face coverings and some of the things that kept them safe.
Forgive me, Professor Murad, if I can just bring you back to the decision to impose shielding. You said earlier on, when I was asking you about lessons learned, communications in terms of how we conveyed information in a balanced way which allowed people to make choices about what was important to them. You also talked about initial messaging. What did you learn, or what have you learned from the way that the initial messaging around shielding was carried out, and what would be improved?
I think that while we endeavoured to ensure that we communicated the advice clearly, as honestly as we could, based on the information that we had, and tried to keep that updated in a variety of ways, I think the net result of the advice on shielding, again, as I said in my statement, was we engendered a significant degree of fear in those who were shielding, fear and anxiety. That was clearly one of the significant findings within the work that I'd commissioned the Patient Client Council to undertake. People felt significant fear and anxiety, not to the extent that they required psychological support, or at least that was the survey information in Northern Ireland.
How would you prevent that happening again?
I think that I think there's also a couple of other important points from that survey, which if I could maybe expand upon. I think the population also communicated in that survey that at times they felt ignored, and they asked for clearer guidance on a more regular basis, and actually a clear rationale for why the guidance was being provided. What was the scientific basis for this? So there were some very clear and strong messages. I think, back to your question in terms of what I do differently, I think that given the profound consequences that shielding had, I think the primary approach to future pandemics should be about suppressing the transmission of the virus and only keeping shielding in reserve if indeed it's necessary. And if it's necessary, then for as short as time as is possible. The other really important thing for me in shielding was it understandably was very, very difficult to take a more nuanced approach to shielding advice when circumstances change. So whenever we had interrupted the link between transmission and severe disease through drug treatments and vaccines, and what we had and what we need to do in the future is to ensure that we give people a greater sense of agency for making decisions about the risks and those trade-offs in terms of risk and benefit, and give people who ever have to shield again a greater sense of control. Because I think the approach that was taken in good faith initially did not fully think through the loss of agency and loss of control that people would experience, and the real fear then that people had about re-entering society, starting to engage again in the activities of daily life.
And accessing healthcare?
And accessing healthcare. I mean, we did a particular survey in Northern Ireland which indicated that, well, we know generally people accessing GP surgeries, people presenting to emergency departments reduced significantly. We did a lot of work communicating to the public that the health service was open for those who needed urgent treatment and care. But certainly, the Information and Analysis Director within the department did some work which identified, I think can provide it to the inquiry if it's helpful, that I think it was up to about a third of people who, if they were offered an appointment to see their GP or attend hospital, would be reluctant to do so. So absolutely, that was a challenge. We did put in place mechanisms where there was remote consultation, GP remote consultations, consultant consultations. But I think that undoubtedly it had a consequence, and we have evidence of that, of people who were shielding not accessing the care that they needed at times.
In terms of Northern Ireland and actually disseminating all of the letters, I think the Department of Health statement says it took a number of weeks for all of the shielding letters to be issued. Does that not cause a problem for people who believe that they may need to shield but who haven't yet received a letter? Is there anything that could be done to make sure that if a decision is taken in future to impose shielding, that actually the message gets out much quicker to those?
Well, again, yeah, and I think it's a very important point. Again, I wasn't responsible for the technical aspects of the operational implementation of the issue of letters. The policy cell in the department worked with the trusts and with the Health and Social Care Board to ensure that letters went out from GPs and trusts to those who needed to shield. Before answering your question, I think the other important point is we did communicate to those that thought that they were shielding that if they didn't receive a letter, to contact their GP or contact their hospital consultant if they thought they should be on the shielding list and hadn't received a letter. So we did have that as a fail-safe. But how
easy was that for people to do, to be able to actually get access to their GP or access to the consultant?
Well, look, I can answer that question, but we did put significant additional investment into telephony services in general practice, really from early on in the pandemic, because again, much of general practice switched to remote consultation. So there was significant investment in technology in general practice in particular. But to answer your specific question, I mean, I understand that the difficulty in relation to the bulk of the letters issued, I understand, have been advised on the 27th of March. Mm-hmm. There were some letters that took longer. The reason being the GPs were advised to prioritise those that they felt were most at risk, and actually had to search their own databases.
There wasn't a centralised database.
There wasn't a centralised database, but then, you know, every pandemic will be different, and the underlying conditions that make people extremely clinically vulnerable will differ depending on the pandemic. So there wasn't a centralised database, but I understand, although not directly involved, the department did provide search engines to be used in GP systems to identify individuals.
And it's just, I'm conscious of the time, I need one further question in relation to IT, particularly in IT systems and telephone systems. The shift to telemedicine for GPs and the use of the telephone systems, effectively, was the GP's telephone infrastructure in Northern Ireland able to cope with that shift, or effectively was the system overwhelmed?
I mean, again, I'm afraid I still live in the analogue area, and IT is not my, area of competence. So others would be better placed to answer that. What I would say was that during the pandemic, we did have to put in place significant investment into technology in general practice. I think those were issues that had been identified by GP leaders in Northern Ireland and had been for some time.
When you say some time, roughly how long? Years?
Certainly, we had conducted the department had established, and I was not directly involved in this work, had established a working group in 2016, which had produced a report, which had indicated three main objectives in terms of general practice in Northern Ireland. One, to strengthen the general practice workforce. Two, to improve clinical pathways and integrated care. And I think the third one was about driving innovation, and issues such as telephony, remote reporting was identified as one of those areas. Now, Ask My GP had been launched in and around 2019, which is a mechanism whereby GPs can have consultations with patients. There was a very low uptake of it initially in general practice because, as doctors, we like to see people face to face.
So Professor, I think if I can just bring you back to the question. Were GPs able to cope with the shift to telemedicine at the early stage of the pandemic, or was the system not able to cope?
I can't answer that question. It wasn't an area within my remit.
Thank you, my lady.
Just before we break, Professor, can you help? You've mentioned introducing guidance on social distancing, reducing contacts, one-way system, remote consultations. When was this guidance published? You said it was before the first lockdown. Are we talking about March?
We are, in terms of within health and social care, yes. The workshop that I referred to on the 5th of March, which was to further develop the surge planning that had been underway throughout February, as I understand it, considered all of those aspects about one-way systems, separate waiting areas, remote access, consultations, and there was ongoing work on those areas from that very early date. So by probably the middle of March, and certainly prior to the first, not prior to, but in advance of there being significant number of cases detected in Northern Ireland, there was separate facilities for people attending with COVID symptoms. So, for instance, they were advised not to attend, but to phone their GP. We'd established COVID-19 primary care centres where individuals were assessed by GPs, were tested and referred on into secondary care if necessary. So all of that planning and preparation and putting those arrangements in place occurred in the time frame from early March up to about mid-March.
I'm not so much interested in the planning. I've heard a lot about planning over the last few months. What I'm interested in is when were the members of the public in Northern Ireland told, keep your distance, reduce your contacts, not planning?
Well, I thought we were talking about the health service as opposed to public. That would have been at the same time as that message was communicated in the rest of the UK. From memory, I think that was around the 16th of March.
So it was shortly before the first one.
Yeah.
Thank you very much. 10 to 2.
All rise.